Okay, so let's stand for the invocation of the pledge, and I'll ask to stand for the invocation, and then we'll pledge allegiance together.
Father God, we come to you this afternoon. Lord, we thank you for all your many blessings. We thank you for allowing us to assemble here this afternoon. We thank you for allowing us to be able to take care of the patients of West Ascension District. Lord, we ask for a special prayer over our community, over our patients, over the staff, over our state, over our country. And Lord, we ask for healing throughout your world. And Lord, we ask for tonight that you continue to touch our Board of Commissioners, as well as our patients, our community members that have assembled here tonight, that we would do your design will for the district, for West Ascension Parish. And these blessings and all others we ask in your precious mighty name. Thank God and amen.
Amen. I pledge allegiance to the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Okay, thank you. The first item that we have is the approval of the minutes from the board meeting of February 5. These minutes have been published.
Minutes for the board meeting held on February 5th.
Have a motion to approve. We have a second to approve. Any discussion? Any opposition? Hearing none, that motion is adopted. Public comment. So we have a 3-minute time period for our public comments, and it has to be the public comment has to be relative to an agenda items. And so we ask people that want to speak that they sign up and they tell us which agenda item they'd like to speak on. So, yeah.
Yes, I have Mr. Lynn Price is for public comments.
4 different places on the agenda. I need to speak. Okay. So you don't have an agenda number or anything.
So whenever those come up, I'll let you know.
Yeah, okay, great. I don't think that's.
So you ready now?
I don't think it's, I think it'll be on the individual.
Individual items? Okay.
Okay. Before we get.
That's fine. If that's okay with you.
Yeah. All right, reports on standing committees.
Yes, sir. All right. So first off, good afternoon, commissioners. Good afternoon, leaders. Good afternoon, community members. I appreciate all of y'all coming to our board meeting for this afternoon. Basically, want to give you a high level of our financials and currently where we are. And I will take a look back from where we were a year ago at this time. So looking at net patient revenue, 1.6 million, the reduction to revenue right at 643,000. That's giving us a total net patient revenue of 1.3, 1 million at that time for net patient revenue. Looking at total net operating, brought another 224,000. So it gives you at 1.2 million. Contract labor, salaries was flat at 400,000 this year. Total employee-related expenses, right at 452,000. Purchase services was flat, as well as 124,000. Looked at other expenses, came out to be 47,000. Supplies was flat at 38,000 for the year, and that's given us total net operating expense of 662,000. Take away the $455 on our capital related revenue. That gives you our total net income for the month, which is $600,677. That is the highest total net income that we have had as an organization since the board has taken over and since our administration. So that is a great month for West Ascension Parish Hospital. You can see everything is in line and trending where we set our budget to be. I would like to thank our nursing staff, as well as our medical records and our billing staff. The coding, the charges are all tied to the net patient revenue. So we had a wonderful month. After all expenses, this is what we was able to net this month, Mr. Dawson.
This month.
Yes, sir. $600,000.
So, and the, I can't read the top of that. One through, one through.
So, yes, sir. So this is January 31st, 2026. So that was the end of the month of January. That's what we had.
What's the right answer?
So this is September 1, so the beginning of our fiscal year to January. So that's fiscal year to date. Right there, Ms. Tanya, you had $1,044,426 for the year. So we are still trending in the right direction.
And tell me, what do you mainly attribute that to?
That's what.
Emergency room? Or?
Your emergency, we have seen that our outpatient volumes have started to come back, especially with CT. You have a brand new CT machine that we have in place. That is the 64 slice. So the volumes are steadily increasing. And we've also had a high flu rate the last several months. So we attribute that as well. So great foreshadowing of where we at right now.
What was the net income for last year?
Okay, yes, ma'am, we're gonna be on the next one. So, yes, ma'am. Yes, ma'am. So that's your income statement there. We go to our balance sheet. The balance sheet, current assets are at 24 million. Total net patient AR are at 6.8 million. Total current assets at 32 million. Total assets, which are liabilities, at 39 million. When you look at 1/31/2025, it was at 37,100,003. You're already looking at 39, so we add $2.5 million to
Is that in
the
that
total.
unrestricted fund?
Yes, sir. Yes, sir. That's your total liability
Unrestricted
and unrestricted.
is 37 right now?
39 million. We added 2.5. Yes, sir. So when you look at January 31st, 2025, last year at this time it was at 37 million. January 31st, 2026, you're at 39 million.
That's quite a bit.
And that's with all of the staff that's here. That's the work of the staff. What they're doing is working, and we also appreciate your leadership for directing us in this way, and it's working.
Pretty easy to lead if somebody's giving you $2 million.
Next, if you look, Dr. Lee, if you flip on to your executive leadership summary, and also community members, I usually use this just shows you our executive dashboard. So this is how we manage day to day. So it shows you the month, it shows you the fiscal year to date, it shows you what we budgeted for and budget year to date. So we look at budget year to date on the actual, we are at 1 million. We budgeted for only 461,000. So we have exceeded budget by 578,000 that we added this year.
So wait a minute. The income side, this is on it's a million on the income side.
So yeah, this is on the income side. So we have added.
It's not additional expenses.
No, sir. No, sir. No additional here. No additional. Everything is in line, and you can see everything is trending in the right direction. And Ms. Tanya, that was one thing that you had asked to look at a clear trending model of where you're at, and you can see everything is trending in the right direction as of now. You see in your sales tax that there was a decrease, and I'm going to explain your decrease where we were, but everything is trending in the right direction at this time. Yes, sir. Yes, sir. So when you look at your sales tax for December was $113,713. This was for both the east side and the west side. There was a decrease in sales tax that was collected. However, we see we're trending back up to 146,000 that was collected for the month of January. So it's coming along. We're still at 837,000, so we are going to exceed the 2.1 million that we collected in sales tax for last year.
And we'll talk more about this later, but, we have these, the industry over there.
Yes, sir.
And Modet, on our side of the river.
Yes, sir.
Out the one, but, we're gonna have to make sure that we look at the sales tax and we know the difference in spending it on recurring versus non-recurring expenses.
Absolutely.
You know,
Absolutely.
I feel like that this needs to be, I would love to see it just go towards capital expenditures
So I'm glad that you're saying this, because when we started and when this new board started, we was having to depend, and we depend on our sales tax, and we're very grateful for our sales tax. But we knew that we had to do the work. So I'll use this, and I use a term that Dr. Levy used in her class, lanyard. So that's our lanyard month. So that's going to our account that we have. So when we start to look at expanding and building, we can look at the capital that we need for that. So not to put that into our regular operating fund, but to just hold that money for when we do as we build out and expand.
So at some point, I'd like to set up a meeting, like I have a meeting with the people that collect this tax.
Yes, sir.
Pay for it, and I will use it. And I'd like to see if they can identify what's coming from CL, what's coming from Hyundai, so that we can see whether that's recurring or non-recurring, or where, you know, is that something that's on their operating agenda, or is it something that we can spend the capital fund on? That's the deal.
Well, I'm glad you said that, because, you know, I do sit on the sales tax board. And I was just, yesterday, I was just nominated and voted to be the chairperson for the sales tax. I sit on that. So I am. So I am the chairperson. You didn't know that. You didn't know that. No, we got it. We got it.
I take back all of that.
So I will make sure that I have our best interests, as well as the interests of all of the districts, both east and west.
The story is that when CF did their last expansion, Paul and I went to them, and we said, we want to know, you know, what is this part of the original equipment, or is this part of your operating cost? And at that time, those people at the collection agencies, they couldn't tell. They told us they couldn't tell. I suspect they didn't want to do the work.
I feel. But now you got me, so.
Congratulations.
Yeah. So that concludes the financial report at this time. Mr. Darby, you have any questions for us? I believe me. Mr. Muir?
I got nothing.
Ms. Mitchell? Mr. Dawson?
No.
All right, so the next is our standing reports. This is our standing reports of the organization. And before I move into the standing reports, I would like to welcome our Chief of Staff, Dr. Andrew Gruski. So Dr. Gruski, glad to have Dr. Gruski and his group that covers our emergency and our inpatient units. Looking over our social service, so total patient visits was at five admits, 1 consultation, observations, as well as the referrals. We didn't meet on the 23rd for MEC, and they was able to approve and accept the report. 0 on your Medicaid admits, as well as our monthly denials. Our physician quality problems were all at 0. If you noticed, your facility quality problems was at 0. Admission denials was also at 0. On our quality review, 1 admissions, again, 6 observations, and the 23 discharges. My wound care was flat at 21 patients. Did not have any specimens that needed to be received in our ER or the or our pathologist review. On our imaging side, ultrasounds for the ER was at 0. ER for X-ray was 94, and ER for CT was at 117. Looking at your volumes, Mr. Darby, we had 475 patients that was registered, and we had 475 patients that were seen. So that was wonderful for the staff. So we're glad to see that. 99% compliance, 20 records were reviewed, 99% on our pain reassessment, and as well as our medication administered prior to discharge. And that speaks volumes to Miss Anastasia and her nursing staff of making sure that they're taking care of our patients, as well as our physicians that are making sure that any time we have anybody with pain, that they're doing everything that they need on that. Looking at our positivity rate for our ER, flu A and B, we ordered 135 with 31 that was positive. That's a 22% positive rate. Strep A, we ordered 97 with 4 that was positive. RSV, 29 that was ordered with 3 that was positive, and COVID-19, 127 and 2 that was positive. So we've seen a decrease, good, but you still have that spread of flu A and B. So Ms. Anastasia practices and preaches to all of us, wash your hands, cover your mouth, and make sure you are practicing distance with everyone. Respiratory therapy stats, 6 ABGs as well as 87 on our EKGs for the month. Oxygen hours were at 648. Mr. James with his environmental care plans and Mr. Wayne, they have completed everything, your generator test, as well as our equipment management plan, as well as our fire prevention, your medical and line isolation. Everything falls in order to where it needs to be for environmental care. And this will conclude our MEC report for the month. And look, I did that in less than 15 minutes. I'm getting better at this, isn't I? Close to 15 minutes. I got you. So, I don't have anything for this month.
Okay, the chairman report, I don't have anything to report. Okay. Let's go to new business.
All right. So first, Mr. Dawson, is our resolution. The first will be your resolution to apply for annexation into the city of Donaldsonville, and I'll turn that over to Dr. Levy.
Would you read it?
Read the resolution.
Resolution annexing real property known as West Ascension Parish Hospital at 301 Memorial Drive into the corporate limits of the city of Donaldsonville, Louisiana. Whereas the West Ascension Parish Hospital, located at 301 Memorial Drive, is situated in Ascension Parish, Louisiana, and is currently outside the corporate limits of the city of Donaldsonville. And whereas the governing body of the West Ascension Parish Hospital Board of Commissioners has determined that annexation of the property described herein will promote the orderly growth and development of the city and enhance the provisions of municipal services to the property. And whereas the owners of the property, identified as West Ascension Parish Hospital Board of Commissioners, have submitted a voluntary petition requesting annexation into the city pursuant to the applicable state laws. And whereas the West Ascension Parish Hospital Board of Commissioners finds that the property, petition 1 and petition 2, is continuous to the existing hospital boundaries, and that annexation is in the best interest for continuous services and for maintaining its designation as a critical access hospital under federal and state regulations. And whereas preservation of critical access status is essential to ensuring continued access to high quality, cost-based reimbursed healthcare services for the rural and medically underserved communities we serve. Now, therefore, be it resolved by the West Ascension Parish Hospital Board of Commissioners of the City of Donaldsonville, Louisiana, as follows. Section 1, the annexation of property The property described as Petition 1 and Petition 2, and commonly known as West Ascension Parish Hospital at 301 Memorial Drive, Donaldsonville, Louisiana, will hereby be annexed into the corporate limits of the city of Donaldsonville, effective upon adoption of this resolution and recording as required by law. Section 2 is the zoning and classification, and upon annexation, the property shall be zoned in accordance with the city's zoning ordinance unless and until amended pursuant to the law. And Section 3, the effective date. This resolution shall take effect and be in full force immediately upon its passage and approval.
Okay, thank you. And Dr. Levy, I want to thank her. She wrote all the whereas and. So, is there any discussion on the resolution as read?
I just think we may need to edit it, or the Section 1. And what you read, that we're declaring that we're applying to the annex, but we're not the ones that declare the annexation. So here we're saying that it will be annexed. We technically can't make that decision.
Change it to recommend that.
Right,
It be
right.
annexed.
It's not our decision to make, but we are just resolving that we want this to happen.
Okay, so change the wording. Thank you.
I figured out I'm on the wrong with it. Yeah, I would just add, and how about this, y'all? In front of the paragraph, just say it is a recommendation of the board of that.
Okay.
And then, so it is the recommendation of the board. I mean, honestly, y'all, I mean, I'm on board with this, but should we just table it to review the draft, to review it further? I want to make sure we're doing this right way. Legally.
Is it because it's the wording or is it
Yeah,
the
wording and
recommendation
the,
of the?
no, I'm on board with that,
Okay,
for sure.
so do we?
Like, to get it passed through the lawyers and stuff to make sure that we're doing it right.
But can the recommendation to just get the process going?
Yes, I think we should vote on, not actually make a resolution. But to declare, just to recommend that we get that process started, tell Sheldon to start the legal and get it. And no, I mean, this is in no way of me being against it.
Okay.
I just want to make sure we do it right.
So let's hear the motion.
So I'll move to recommend Shelton get this process started and looking into annexing the property as discussed in the resolution.
Okay, so we have a motion, and we have a second, any discussion? Any opposition here, so that motion passes. All right, our consideration, next agenda item is consideration to establish the West Ascension Parish Hospital nonprofit foundation. And Mr.
Price is on this one. Yeah, right.
signed up to talk on that.
Good evening, everybody. Glenn Price, President of the Sunrise Community Group of Donaldsonville. We consider our organization to be a watchdog community organization. So we keep eye on everything that's going on in our community. We're involved in everything in our community. We just want to see as much as we can improve in our communities for our residents. I seen this on the agenda concerning the hospital establishing a nonprofit foundation, and we think that's good. It would be good if the hospital can have a nonprofit foundation. The only thing is we hope that when you put that together and you put your mission statement together, that you include all our residents. What I mean by that is, here in Donaldsonville, we don't want anybody else to forget this, that most of our residents are at or below, not most, up to 50%, 44 to 48% of our residents are at or below the poverty level. These people are struggling just to pay their bills every month. So if you take a close look at Donaldsonville, you can see the poverty. One of the things we noted, and we get calls from residents all the time, is that they're struggling just, like as I said earlier, to pay their utility bills. So with this foundation, if we can put some funds aside, maybe help people with things like that. There are agencies that do help, but they run out of money fast. Because a lot of people contact these agencies to get help. But since we're in great financial shape here at the hospital, maybe we can put some money into this fund initially. I'm sure there's other money, state money, federal money that we can tap into through grants. But the hospital is in a position to put some money into this foundation so that we can help our residents when they need it. So that was my comment on this particular issue. Like I said, I got 3 other issues to comment on, but I'll just wait till they come up.
Yeah, thank you. Okay, so now we have consideration to establish the Ascension Parish Hospital non-profit foundation.
All right. Well, thank you, Mr. Dawson. Thank you, Mr. Price. I would like to share the mission for the West Ascension Hospital Foundation. And the mission is to provide accessible, affordable, and high-quality healthcare services to all members of our community, regardless of their socioeconomic status, while maintaining excellent standards of medical care, professional integrity, quality volunteers, and community projects within our 16-mile surrounding radius. And our vision is to build a healthier community where every resident can access quality healthcare services, preventative education, and community resources needed to maintain a holistic approach to everyone's well-being. And I would like to, y'all already know my go-to, Dr. Cynthia Buggage, but Dr. Buggage will be our foundation's director as well. And the foundation was brought to my attention several months back. And I told Dr. Buggage, I said, I need you to do X, Y, and Z. And Mr. Dawson, she didn't do X, Y, and Z. She did 1 through 20. And she took it and she ran with it. And she told me, she said, Shelton, the need is in our community. And she broke it down to our patients that we service, our community, and how people, like Mr. Price said, are struggling. And we want to be able to have a foundation to where we can start to work outside of the bounds of what I can do as a hospital. So, Dr. Buggage, I appreciate you bringing your vision, and I appreciate you for allowing us to develop with your articles, with your bylaws, as well as to be able to move this foundation forward. So, I mean, I seek for a consideration on establishing the first West Ascension Parish Hospital Foundation.
Let me say that I've been a part of forming a few of these nonprofits. It takes a lot of dotting I's and crossing T's.
Yes.
And I'm not in any way against that. I think it's a good idea.
Yes, sir.
I would though like to see more information.
Yes, sir.
For example, what's financial prohibited us being a government entity? What are the steps in forming this, and who's going to do it?
Everything.
You got it all right
I
there.
got everything for you right here. Yes, sir. Everything. Yes, sir. Yes, sir. We have everything. Dr. Buggage, you want to?
I was going to say that the foundation itself is not going to be a government entity. It will be a nonprofit 501c3. So then the things that we will be able to do would be a little different from what the hospital would have to do, because of the fact that it's under the parish. That was one of the things that the state of Louisiana, when you go online to do the registration, if it says certain words, it kicks it back and say, can't do that. Saying parish was a no-no. So that's why we're going to actually be correcting that and making it West Ascension Hospital, a nonprofit, and it's going to be West Ascension Hospital Foundation, Inc. You will have several entities under there. We have the governing board, and then you'll have an advisory committee, and the working fundraising committee will be made up of people across the parish. I have already sent an inquiry into the Attorney General's office to ask about if we can have elected or appointed officials in on the advisory side. So there will be nothing ethical or unethical about it. I'm waiting to hear back from them so we can share that with Mr. Shelton, and he can share it with you guys.
So I'd also like to know, what can this contribute to? What the vision, what is, what you
Right.
to have that incorporated?
So, Mr. President, here's what the chairman said. He wanted to do some things. We have a lot of people come to the hospital asking for things like the community projects that are going on, the school projects that are going on. We can do some things in reference to medicine and health and some research, the way we have it set up. We can also do some things we have tied in with the Ladies Auxiliary so that they can be able to do the volunteer work that they are doing, and it would not have to come from the budget of the hospital. They have, for instance, an event happening in April where they go to the nursing home and provide the residents there with some care bags. Then that wouldn't be the responsibility of the hospital to do that. It would be from their fundraiser. So one of the things that I suggested, and Madam President, I sat and talked with Solomon about doing the first fundraiser being a luncheon that will provide for the funding with a goal of $25,000 initially. It may exceed, we don't intend for it to go below, but it would be so that they can provide those events and activities. They're planning for another breast cancer awareness event. That wouldn't come from the hospital, that would come from those funds raised. They're planning for a doctor's day. That wouldn't come from the hospital, that would come from the Ladies Auxiliary. So some of those things, like for instance, the Little League football team asked the hospital to help them with the programs for the football team. That wouldn't come from the hospital. Whatever surplus they even have, it would come from that event. And the free clinic day, we're going to start fundraising now for that so that when the time comes around, whatever we have to put in for that, that would come from there, that source instead of from within. And it's kind of like it leaves it open for other community projects. So that would be, it wouldn't be sort of limited to those things, but those are the things that we've seen so far that we've done around. And of course, we're talking about the community garden. That would be also where we would get grants for the garden. That would be in the back. I don't know if you guys have seen the beds and the greenhouse. And then we're talking about putting some citrus trees across the street where the fitness piece is over there as well, so that the community can, if there's something there that's been bared, harvested, then they can help themselves.
I mean, listen, I know it's gonna do great things. I'm just, I get a little bit nervous.
Well, no. And none of us, I would not put you in that position.
This is not gonna be the hospital's.
No, sir.
Foundation.
No,
It's
sir.
gonna be an independent.
It's an independent
So we need to
foundation.
find out what happens when the hospital funds it, what can the hospital fund it, and what are the restrictions on that? I'd like to just get some more detail.
I don't think it's
We would not ask the hospital to fund anything with this organization. It would fund itself.
So the word hospital would be taken out.
So we can take the word hospital off too, but, just say, what's Ascension Foundation nonprofit? What's Ascension Foundation
That
Inc.?
would be better.
Okay,
I think it's a great idea. Why don't we just keep this on the agenda every time we come back and just keep this ball rolling?
okay.
I think it's a great thing, but in the same vein as the last resolution, I don't think this is the vehicle to do it, but I just want to voice my support for it. Just because I don't want to pass a resolution thing or whatever. I think it's a great idea. Let's keep it going and get the application going. If y'all want to vote on us, I don't think we vote on anything.
And I wanna say, I know you say you have to take parish out, but I do kind of like the idea of keeping hospital because it's still an extension of what we're already doing. So I like it because
Well,
it's
it's
just
not,
a,
right, and it's not unusual to have hospital
Yeah.
in there.
yeah.
The, Opelousas General
That's what I did.
has a foundation, and it's Opelousas,
Maybe
General
we can
Hospital.
set up a meeting with those people, and, or I don't know if y'all already done that, but just to make sure we're doing it right, like, it's in the same vein as.
Would it be the wording, this right here, that you're
I don't think we would need I don't think we need to pass any kind of resolution on it. I think we need to be careful on passing a resolution on it because we don't want to be too intertwined.
right?
But we fully support it, you know?
Thank you.
Okay, so we're gonna pass on that, is that what I'm hearing?
So how soon will you be able to get like, so what's the plan going forward as far as like getting the information we need, like how?
You will have it by next week,
Okay.
because it's already there.
Next meeting, we'll put this back on the agenda.
But we'll have information next week.
Next week, you will have everything, because everything is already done, the initial
It's
meeting.
a great
Yeah,
idea.
the initial meeting, your foundation
I'm
meeting.
on board, I
Yeah.
just don't think the resolution is.
And I would like to be a member.
Just want to be a member.
I would like to be a member.
As a matter of fact, we were looking at that when members are rolled off of this board, if they were interested, then they would.
They also have like charitable balls, like all the things. Yes.
We got it, Doc.
We're good.
Good.
Okay, back to see us next meeting.
So get us the information next week.
Next week you'll have it. You will have it next week. Yeah, you may have it tonight.
All right, we have the next item is report, primary health care clinic and rural health.
So basically, Ms. Mitchell, you remember back in August, you asked for an comprehensive review of what it would look like if we was to do a primary health clinic as well as a rural health clinic. So what we did was we started working with our partners, Mr. Matt, and they was able to build out everything that you asked for. So you have the pro forma, you have the information, you have the conversion, and we wanted to be able to provide that. So as you are making those tough decisions on what's needed for the district, you can take this and have this roadmap that is already completed, that shows you our data and what our data is projected to be for a primary care or rural health clinic. So I wanted to allow Ms. Crystal, Ms. Matt to
Hi,
take it over.
everyone. So this is a little bit unique, speaking into a little microphone. But for those of you that don't know me, my name is Crystal Mitchell. I'm with Southern Evals. This is my peer, Matt Sigler. I have been your regulatory and operational consultant for the last almost 2 years, right? So that's my baby. But my partner here, what we do also, we have a division that starts primary healthcare clinics, and we also do the rural health conversions all over the state of Louisiana and all over the nation, but Louisiana is our baby. So with that being said, you guys asked for the information to make an informed decision. And so what we did was focus on primary health care because you guys, that's the one critical piece that West Ascension's missing. As far as a critical access hospital, this is one of the only ones that does not have that does not have your primary feeder. And so as Mr. Glenn mentioned, we're talking about your community, your demographics. We have already identified through your social determinants of health what your needs are. You guys, you can drive around, you know what the needs are here. We know what the community is telling us. We know what's coming in through the volume of the ED. But the problem is that you will never be able to grow beyond those bounds if you don't have a feeder source, right? So you can go all in the community as you want, but how are you're responding to a tertiary prevention now. They come to your ED for a problem. How are we getting ahead of that? How are we looking at a comprehensive healthcare cycle? So in front of you, you're going to see 2 reports. The first report is your full business proposal and your business plan. The second portion, you're going to see a divider, and that's the feasibility study. The feasibility study is in depth. It's for your community. It's for your demographics. It's looking at Also your location, and we'll let Matt, my partner, talk about that in just a few minutes. But additionally, you will get an email and it's the full pro forma. What we wanted to do, and what we wanted to be very cautious of, is the political landscape and where we are at from a Medicare and Medicaid billing perspective, right? We know that the primary payer source here in our area is Medicare and Medicaid. And so being willing and understanding and making sure that that foundation is laid the right way up front, and making sure that as we convert into an RHC, which is, if everyone doesn't understand the acronyms, it's called a rural health clinic. Why is that important? Matt's going to talk a little bit more about the business side of it, but basically, a primary healthcare clinic will be built first from a provider, and it's called a fee-based service, right? As you are getting that up and running and you're establishing your norms, your standards, your foundation, you begin the process into the conversion into an RHC, a rural health clinic. Why is it a rural health clinic? Well, you get a different rate of billing. You get all these options that you can continue to grow and expand upon, such as immunizations and feedbacks and those sorts of things that what we want and what's the focus here at West Ascension. So this is the outline that we propose. This is not anything that isn't being done across the state. Your partners down the road have done it. There are clients as well. So we're very well versed in this, and then have a mainstay from political conversations as well, making sure that we're part of those further discussions and that you're aware of any billing and practices and changes. Okay. Now, why is this important? Right now, as I mentioned, you guys don't have another front door other than the ED. So having aligned primary care for your front door, it allows for coordination. It allows for effective utilization, and it previously impacted the restriction on growth. We're looking at swing bed. You're looking at outpatient, driving those volumes. How do you do that? Well, you go to your primary health care. They send you for labs. They send you for x-rays. They send you for a mammogram. Where are those patients coming from now? Our ED. Okay? They're not coming from a variety of other primary healthcare clinics around. We have to take control of the growth, and that means taking control of the health of our citizens and around our surrounding areas. I want to just share again that this is not experimental, okay? This is proven rural sustainability. And when we're looking, again, from a rural health transformation, we're looking at the big, beautiful bill. We're looking at down road projections. This is how that you're going to remain sustainable in this landscape. All right, the point of all this is really, it's simple, and it's to protect the future of West Ascension. It's to protect the future of the health of our citizens, whether they're adolescent, early childhood, into our senior citizens. So when we're looking at coordinated efforts, we're looking at where do they go for care? They may go into Baton Rouge, they may go into New Orleans for surgery, but guess what? When we're able to have the full continuum of care, we can care for our patients right here. We can look for promoting their health and making sure that they're taken care of, so that auntie and cousin and daughter can come down the road and it's not making a stressor on the family. So those all are the things that we have to think about when we're looking for their growth for West Ascension, but for taking care of our patients. So primary health care becomes the entry point for our hospital. It feeds our admissions, it strengthens our observations, and identifies swing bed candidates. Swing bed candidates you're going to hear a little bit about, and you're going to see this in the growth of the organization. And so while we've applied for grants and all these things that we've been allocated and we've had mention of in previous meetings, this is continual growth along that spectrum. So as someone discharged, you have a primary health care to go to. So they're continually being integrated into the system, and then you're controlling the utilization and you're controlling the outcomes of your patients, right? And then that helps you to protect your funding. To be quite honest, when we look at utilization, we look at 72-hour returns, we look at 30-day readmissions. We have to be able to prove from a quality standpoint all of these things. So when you're looking at the quality outcomes of your population, this is where it starts. And we're missing the piece that it starts right now, and this is how you continue to grow. So as we talk about long-term sustainability, not just short-term net expansion, not just the next project in 30 days, this is long-term, this is strategic growth. This takes months to build out and a year to do an RHC conversion. But with that context, I'm going to turn it over to my partner, Matt. He's going to walk you through high level of the feasibility analysis and a little bit of those financial projections that are going to support this plan. Now, I do want to share, when you get a copy of this, and you're going to see this on this slide, I think you guys have this slide, you're going to see two. The reason we did this is knowing where we're at now, and I'm helping with Anastasia and the team to build out the behavioral outpatient clinic. We want to show you what that impact is going to be from reimbursable and outcome and how that's wrapped into the RHC when you do identify that accreditation status. So it's very important to take a mindset of projection and future growth, but also what are you currently doing that could be even benefited greater in the greater context.
How are y'all doing this evening? My name is Matt. All right, can we get the projections?
We have slides.
Oh, they have the slides. Okay.
Gotcha, okay. As you can see in front of you, so looking at you've got two different pieces of paper with the numbers and stuff on it. So that you're looking at the primary care projection, I think is what you've got, and you've got the behavioral health addition. All of that's looking at is your most common codes that are billed, your most common startup processes, right? I look at your clinic, and as you're converting to a fee-for-service as a primary care, opening up that practice, what's that growth look like? How do we stage those visits? How do we increase that? So you're going to see that, like, lower numbers. You'll see our first, I think our average is 11 encounters a day, right? We shoot real low there. You go through the conversion process, we increase the numbers. The whole time you're building up your patient base, you're following, you're wanting to also, we're going to be converting to an RHC, which is a bunch of licensure things to get enhanced reimbursement for both your Medicaid and Medicare services. This year, the cap for Medicare is $165 an encounter, right? The patients can come in and be seen. They can be seen repetitively. It's a big benefit there. With the behavioral health piece, you can add additional encounters into that as well. So what you see, just a second, folks.
I would like to share, when you get your pro forma, it is, it's a lot to digest, okay? It is a full pro forma, so it includes all the expendables, it includes your EHR, it includes like registration and your education, all the things that are going to be comprehensive from day one start, building it out, and the RHC conversion. It's projected out over...
So like at the end, your P&L is a 5-year projection. We give an estimation on what that growth looks like and do our very best, obviously, to see kind of like as we're adding staff, as we're increasing salaries and doing all those steps, benefits packages, all that factors into it. Try to give you the most dialed in, projection of what we can based off the data we have available at the exact moment. So on P&L forecast, I'm looking at, what information we tell you. So I'm looking at, obviously, anytime you're doing startup stuff, there's always taking a loss, but you look at a 5-year projection potentially of profiting about $400,000 by year 5, assuming we get to an encounter rate of about 35 visits a day. You look at the growth trajectory. We've done dozens and dozens of clinics. There's a stage, they slowly grow, right? There's always, you have to establish your footprint, establish your providers. Anytime you get providers from the community, so that's better. You want to help push those things along there.
Let me ask you guys a question.
Absolutely.
What is FFS?
Fee for service. So that's primary care. So that's not RHC. So you'll see FFS, that's all fee for service set up. That's just a normal doctor's office. There's no special licensure. That's just a normal clinic. Yes, that would be what you have now when you open a practice before you go through any licensing and
we don't have anything now.
We don't have anything now.
Yeah, yeah. But that will be the first step. So that is step 1, is fee for service.
Year 1 with the red, that would be a profit.
That would be a profit loss. Because anytime, so like I always take the approach of we're starting up, we're brand new, we don't have anything. I'm not going to shoot you to the moon and be like, oh yeah, we're going to make so much money on this. It's not going to be just feasible, right? You've always got to get established. There's always things that have to happen to get you up and running. It costs, and bringing patients in and making shift in that community perspective. I want my care here instead of what they've always been doing, right? So we always shoot that first year low, and then you roll into year 2, you're going to see RHC. So typically it takes about 12 months to go through that conversion process. What I've done most commonly is as we're going through getting that fee-for-service clinic, that primary care clinic set up and started, we're also working on things to go RHC. so that it all kind of happens, smooth transition, rolls right into that, goes through licensure, accreditation, and then we're applying for the enhanced reimbursement rates.
So what is your job in this?
I do all of the licensure, I do all of the paperwork for policy and procedures, I ensure compliance for surveys and regulatory bodies that come in to say, hey, we're doing everything that we have to do to comply with these rules.
How would you summarize that, for us, for
Yes, sir.
the rural health clinic?
Yes, sir.
Or what, more than that, or is it just rural health clinic?
No, so this is a separate project, right? Just like every other hospital, it's standalone. And so the feasibility study, the pro forma, and the business plan were the first steps. We've been, obviously, like we're a part of, and we've been retained for your services, but this is a separate entity that has to stand alone because it's outpatient, right? And so I think your question, and correct me if I'm wrong, is how are we included in this piece? Well, we're already included in all of the cost of consumables as you guys retained our services to carry this out. So what we do, it's a full turnaround, it's a turnkey package. So we get all the licensing done, all of your policies and procedures like Matt helped. We have basically a package that you start a clinic. This is all the things that we need to do. We walk you hand in hand to make sure they're all done. So we have a very intimate relationship with the accrediting bodies that know us. And again, we have our own clinic, so we know this like the back of our hands and help with across the state. And then that RHC conversion, we lay the foundation right the first time. So as you're laying it for the fee for service, there's no point in being redundant in the process. If you lay it right for the accreditation, then it hopefully will cut down time. We say 12 months, but of course,
I can't control LDH. Is what it boils down to. I can't control the other entities that have to be involved with the licensing pieces. There's always nuances there with the accreditors, their schedules to come out and actually inspect the clinic. On our side of things, we prep everything and ready to rock as fast as possible. But we always like to give that caveat, right? The state moves as fast
we've done
as
it
the state
fast,
moves.
like super fast. But
So
again,
y'all trying to get started on this tomorrow?
oh yeah,
Yeah. How does it fit into the new hospital? Like, is it beneficial to get it started here?
oh yeah, without a doubt. So I'll kind of give some examples of why we're behind the 8 ball, right? So you saw your inpatient volumes. There is no reason that the volume should be there. Absolutely zero. You should have a primary feeder source, which should be your primary care physician. Grandma Smith comes to the doctor and she's having some breathing difficulties. We send her from primary health care to get an x-ray. Oh, she has pneumonia. Grandma Smith needs to be admitted for observation, or she needs to be admitted for inpatient stay. How did Grandma Smith get treated in the first place? She didn't. She stayed at home. She probably got septic and then got sent to a higher level of care. So there's a whole continuum of care that we're also missing. Additionally, we're looking at immunizations and things like that. Like, we're missing out on all of that. Now, as we are building, we're also concurrently right now, as of today, too, all these things are newer and a revolution is, or evolving, the swing bed program. So we talked about the swing bed. We just got calls today from the grants. Government is kind of like opening back up. We had the delays and those sorts of things. So that's getting kicked off. But how do you feed a swing bed program from primary health care? So while we were delayed on the swing bed program from things that were beyond our control, now we got the call, well, how we can have all the programs in the world, but if you don't have patients to use your services, then what good are the services?
What is your projected cost?
Yeah. So, I mean, I guess, can you rephrase, like, what are part of you asking about? How much does it cost to?
What's that gonna cost?
So the swing bed program is a grant. It's fully funded. It's already been, and that was allocated back in.
What do you, the rural health planner has somebody gonna do to help us there? What have you done in the past? What do you project to do? What's our cost?
I'm thinking, basically, you would like to see a specified budget of what it's gonna take to stand up the clinic.
Yeah, that's the performance.
Yeah, that's the performer that is done, that you're gonna receive on the email.
I like to see myself
So it is, it's very detailed.
It's several pages of the performance. It is hundreds of data points that would be a massive packet on its own. So we will get that to you, absolutely. I've covered everything from projected expenses from staff, from what the FF&E might cost, all those things. It's best guess based on scenarios that we were talking
It
about.
would lock.
Just do it.
Yep, so, so we.
Actually, ideal to do nurse practitioners.
Nurse practitioner with a collaborative. So we, yeah.
Maybe this is you.
We're kind of going through the same right now for the employee health program as well. It's not on the new business agenda, but a lot of these roll up RFPs and then employee health from IMPs, they need collabs, they need physicians that are willing to do it. So if we're going to recruit those externally and to be employed here, we need to get them on our same practice insurance, and then our physicians can collab with them, and then they get to.
So ideally, as well, you're gonna get the electronic copy because it's the best representation you can get. It's
It's a digital
very
document.
interactive. And so you'll see it, and there's like 12 tabs at the bottom, and then the assumptions for each. And so it will make more sense when you see it electronically, but it would bog down the system and like probably shut it down.
Just to kind of give you an overview of what you'll find in there, right? So I've got you broken down into two categories for each section. So you'll have your fee for service, which is your primary care setup, and that's going to be broken down into two sections. I've got your fee for service volume and then your fee for service revenue. And I break down looking at what's your payer mix for the community, what do we anticipate the daily encounters to look like, and then I extrapolate that out to monthly and yearly. We look at your E&M codes, your E&M utilization, and what we anticipate that to be, and volumes, and break all that down in there. And then we go to revenue, and then we apply what's the current rate on the physician fee schedule, how's it applied to those rates, to those encounters, and then obviously that's how we come up with our calculation of what the additional revenue would be.
Pretty,
Does that make?
pretty sure it's clear we're gonna make money on it. It's just, because everyone we toured, every modern hospital, this is what's going on.
Yeah. The other thing that, and not to, just to kind of add this out there too, because your position and proximity to larger cities, as the census continues to grow, as they redo those things, the urbanized area that is generated around those areas, those communities, expands further and further out. And if you get into a position where they withdraw your HPSA designation, which is your health provider shortage area designation, you're no longer eligible to participate in the RHC program, which means that you'd no longer be eligible for the enhanced reimbursement on Medicare and Medicaid. Yes, you grant once you're licensed and accredited as an RHC, you're grandfathered in no matter what changes in the community. We were just working with a facility the other day. Their community was proposed for withdrawal. We were able to get things done quickly and get them put in place. And we had another one, same situation, but they were able to do a deep dive study and were able to overturn the potential withdrawal of HPSA, so they had plenty of time to make their decision. I just want you to know that that's something that does happen very commonly when they look at these census tracts and how that expansion goes out towards other rural communities. They draw that urbanized area around that. And
I haven't looked at the numbers. How close are we to that?
I don't have it right in front of me, but it's drifting. It's drifting close. It doesn't move quickly. Obviously, census is every time you want to make sure you're not in that danger zone. So
Question.
yes.
Looking at the profit and loss, but like with the revenue, like these are estimations, right? Like year one, year
Yes.
two. Is this considering the clinic that we already have as far as like estimated patient value?
So, which, we don't have a clinic.
Oh, so you guys talk about like a clinic, the one like across the street?
No. So there is no primary healthcare clinic associated with West Ascension.
But it will provide some of the same services?
Yeah, so different patient, different demographics, your patients, and then they cannot go for an RHC status. That's the other thing with you guys that are going to be very different, and that's what critical access hospitals really capitalize on in expanding their footprint.
Transferring from upfront FFS when you start year one, probably 12 months, and you go to RHC, is the RHC reimbursement comparable to like the FMP UPL reimbursements compared to normal state rental fees?
A lot less.
Yeah, so like when we apply for our pro fees, and me and Shelton work together on this. There's certain programs that you can enroll with in the state if you're a certain type of hospital, where you get upper payer limit. Basically, you take your fee for service fees, you apply it to the state, they run a formula on it, and it comes out to a certain amount of money. They get reimbursed, so you have to take up for it. That's their volume and need work. Okay, So I'm asking, is the comparative change in FFS to RHC, is that comparative change at the same percentage point?
Roughly. So when you look at at Medicare, they've set the cap now. So there's a cap each year up to 2029. And I've detailed that in the report. So this year's cap is $165 an encounter, and that's all cost report driven. So as long as our costs exceed that, right, we'll stay at that cap of 165. If for some reason our encounter rate after the cost report comes, it's just below that, they'll obviously adjust down. So your Medicare rate could potentially be as high as 165 this year, and will incrementally grow, I think, up to 189 at the end of the 2028 period. For Medicaid, that's an algorithm that the state runs. Roughly in this area, I've seen anywhere from the 120s and up to 130s-ish, but it's all dependent upon the services you offer, how much of, so there's a litany of services you can offer in RHC that qualify as RHC encounters. The more of those you offer in that space, the more likely you are to get that higher cap.
It's on the facility and the trophy side, it's on both sides.
Speak on that side. So tell me that.
I'm just wondering if y'all's RHC kind of enhancer, and if you call it whatever, for doing purposes applies to clinic only or also the pro fees?
No, it'd be the encounters on the clinic side.
Yeah.
Okay.
Just clinic.
And I know in our situation, you know, is there a fee associated taken off the top before it goes to the hospital, before it goes to the board, or?
No, this would operate to qualify for these things. This has to be a part of the hospital, so it will be underneath the hospital's license. It'll be underneath the hospital's tax ID, all those things. It's an extension of your facility.
So there's no more fees off the top before it gets to where it needs to go.
No, it's expanding the footprint.
Yeah. No, yeah.
No, and we can give an example of the fee for service, like what an actual normal visit is versus.
From my clinic, my wife and I have. So that clinic went from our normal visit, I think was in the neighborhood of about $45 an encounter for Medicaid. Once we went through RHC conversion, our rate got set at $112.63. And so like we had a big bump up, obviously that helps out in a rural community. We're in the town of Jonesville. And our Medicare was $152.
You can kind of see, I mean, it's literally almost double the encounter. That's why you want to do the RHC conversion.
Especially with your high, you have a lot of Medicaid, a lot of Medicare patients out in this community. That's going to benefit the hospital from that side. It's also going to benefit the community because you've got access to care. They can come in and be seen and you get all the services they need. And it's a CMS program, so no charge.
Okay, any questions? There's no action required here.
No action required.
Thank you.
Sir, thank you.
The next.
Okay, item number 4, electronic record.
Oh yeah, they just keeping me busy, But it's rolling. We are hitting our targets, and it's the same from last month. We have been working nonstop with Epic, and we are on target for our 9/1 go live day. That's it. So all's good. We've signed, as of today, 14 additional contracts that's dealing with Epic. All of the breakdown. Mr. Dawson and I had our meeting Tuesday and Monday. And we went over, we looked at all of the Epic implementation that we have and all the fees that are added up. So we're working on that.
Well, I think it wouldn't be a bad idea to kind of give a order of magnitude of what we're talking about here, because all of this.
It is not on you. So you think about everything that we're having to do, from our core point engine. So our interface engine is everything that we deal with that's third party. So for example, we are making decisions now on, are we going to keep a full service blood bank, or are we going to go to an emergency release blood bank right now? So those are questions that NEC is working. If I keep a full service blood bank, then I have to look at 5 additional interfaces that we have to run with Epic. You go to emergency release, you cut that out and you don't have those validations. So you think about just a blood bank is I'm looking at around, we said $36,000 that was not in the initial Epic implementation. When you look at our Epic for year 1, we pay the Epic fees, then I have to pay the FMOL fees. So those are separate and we have to pay that. Good thing is I have worked that through our budget also, This is part of the,
Do you remember approximately what the fees were and or the cost was in the first year?
so cost first year is $750,000. $750,000. Year two is gonna bring, we're gonna be down to around 330,000. And Mrs. Lynn, you remember, we looked at the projections from year one through year five. So when you look at year 1 through 5, we're looking at $2.6 million. The good thing about this is that we are going to be working with rural transformation grant for the One Big Beautiful Bill. And we do have that as one of the initiatives. So we're putting all of that together so that we can bring that back and be able to be compensated for that.
I mean, I'm all for Epic.
Yes.
We know that's the right path to go,
Yes.
but I don't aware that it's also.
Absolutely. Absolutely. And what we have done, we have put together with Mr. Jerry Norman, a standing spreadsheet. So you will have that spreadsheet which shows all your fees. It's going to show everything that we've purchased so
And
far.
it's gonna all be in the budget when we get that.
I already got it in the budget for you. Yes, sir. Yes, sir. So that was your Epic. Any questions on Epic? I don't need any actions tonight.
Thank you, Joe. All right, item number 5, we, Lynn signed up to talk on this also. And then report status on 2023 and 2024 audit recommendations.
Everybody on this particular issue here. Didn't really want to go public with this, but had no choice. While I was still on the board, it became to our attention last year, I think around July, August, that the auditors found a deficiency in their report for the 2023-2024 audit year, fiscal year. And I'm gonna go directly to the deficiency that they printed out to us. It says that the former CEO final check shows a correction paid in the amount of $80,460. There is no documentation supporting why the payment was made, nor were there any board approval noted. Based on the vacation policy, got it right here, the payment would be in excess of the accrued vacation policy, as the most that could have been paid out based on the vacation pay policy would have been only $8,940. The auditors went on, talked to management about this, said management will inquire with the former CEO as to why the payment was made. The CEO would have to provide documentation showing that it was approved. If there was no valid reason for the payment and no approval of the payment, the hospital district would request that the former CEO pay back the difference. Well, the difference based on how much he cut the check for, which was $80,460, he should have only got paid $8,940. He owes the hospital $71,060. When I was still on the board, I was adamant that we were going to get this money back from Vince Catala, the former CEO. He cut a check, signed a check to himself for this amount of money. The vacation policy only allows you to get 3 weeks of vacation pay. You cannot carry it over. No employee is allowed to carry over vacation time to the following year. Any unused vacation time is forfeited by the employee if it is not used in the current year. Vince Catala, like everyone else, was an employee. Bill, you and I communicated through text messages about this issue several weeks ago. In your text message, you said to me that this issue, while you were still on the board, and that's right, and I was adamant we get this money back, we complied with the recommendation from the auditor. The auditor did not recommend that we try to call back any part of this money, because we did not know what policies or agreements between he and the board was in place to compensate him for the last 40 years or so. There was no board approval. There was no other policy other than the vacation policy. Vince Catala took Vince Catala
You got
cut.
5 seconds.
Bill, there haven't been 3 minutes yet. But I'll just end it with this.
Right now.
We're expecting the board to do its job. If you do not get this money back from Biz Catawba, we, Sunrise Community Group, will turn this over to the Attorney General's office, to the District Attorney's office. We'll turn this issue over to the media, and we'll let everybody know in West Ascension and Donaldsonville that you allow Biz Catawba to steal $71,000 from this hospital.
Okay. So now we have, Shelton, if you will give us a report, at 23, 24.
Yes, sir. So from the financial auditor report, the first condition, during the audit, there was noted several accounts which required adjustment in order for them to be properly reflected in the year balances. These accounts included property and equipment, accounts receivable allowances, investments, and receivable. The recommendation from the auditor was the district should evaluate its accounting and financial reporting function. Specifically, the district should consider the following: take a more of a role in preparing and recording journal entries historically proposed by the auditors as part of the audit, and implement procedures and controls to ensure those accounts payable. That action has been completed. We do have a formal process in place, and that was reported to the auditor. Second condition was in accordance with the Louisiana Revised Statute 24.513, the hospital district must complete and submit an audit of our financial statements within 6 months of the close of the fiscal year to the Louisiana Legislative Auditor's Office. The recommendation was that the hospital district should file their annual financial statements audit within 6 months of the close of their fiscal year, and that has been addressed and completed. And the next was, during the audit, there was several accounts which were resolved, which required adjustment in order for them to be properly reflect the end of year balances. And these accounts included patient revs, property and equipment, as well as inventory, and that was resolved. What we did was we looked at the resolution, we made sure that our AR balances, and we make sure that accounts payable and receivable, as well as our financial department and our CPA firm is closing out those accounts every month for journal entry. Next condition was the hospital district contracted the company to renovate the hospital in a total of excess of the public bid law pertaining to public works, and we did not advertise for those bids. The recommendation was the hospital district should implement procedures to ensure the necessary quotes or bids are obtained and necessary information is documented in order to follow Louisiana Revised Statute. That has been completed. Mr. James and I, we work on any type of, if we have to do anything for as a hospital, we make sure that it's within the Louisiana Revised Statute. The next was during the assessment of the internal control over financial reporting, the deficiencies for the design controls for bank reconciliation for April 2024 wasn't properly reconciled to the general ledger. We have put the proper internal controls in place, and that is completed. And the last was during the 2024, the former CEO final check showed the correction pay, like Mr. Price said, in the amount of $80,460. There was no documentation supporting the why the payment was made, nor was there any board approval noted. And based upon the vacation policy, the payment would be in excess of the accrued vacation policy. The recommendation from the auditor was we recommend the hospital district follow the payroll policies where employees of the hospital district are terminating employment. It is recommended that support and documentation to keep for these types of payment, and the policy has been written, and anytime we have that, we make sure that we're following those policies. So the financial audit report as well as the findings have been submitted. They were submitted, they were accepted by the auditor and the Louisiana Legislative Audit. So
Let me make sure that I understood that correctly, Shelton. There was a finding that said that the former CEO was paid in excess of the current policy.
yes, sir.
And then the recommendation from the audit people was that the hospital go and look at those, procedures and bring them up to date.
Yes.
Was there anything in there that said they, need to go back and try to claw this back from the former CEO? Did they say that?
Not the recommendation from the
It wasn't a recommendation.
The recommendation was the hospital district follow the payroll policies when employees of the hospital district are terminating. And we make sure with Mr. Kevin that we have all of our policies in place as of now.
How long did Mr. Donald, how long did he work at the hospital? Do you know?
Over 40-some years. Over
I think it was 56 years.
56 years?
56 years. Okay.
The audit was conducted in 2020. Wait, it was for 2023.
Yes, sir. For 2023, 2024. Yes, ma'am. Yes. Yes. Yes, ma'am. Yes, ma'am.
So, question, is this board like responsible for what took place under the other boards?
As legal counsel?
No? Okay.
Anybody else have any questions, comments? No?
Mr. Kevin, you want to explain your policies on vacation and payroll?
Yeah, definitely. So what's occurring is, of course, everyone knows whatever you approve is owed to you because that's the way the time is. So at your time of separation, whether voluntary or involuntary, you are paid whatever you have accrued within your PTO balance. We recently, under the administration of Mr. Anthony, wanted to have an operative way of giving back to the employees because there are oftentimes when situations happen with a home, whatever, personal, family, where we allow the employees to buy, the company buy back 40 hours of their time. And in some instances, other things may come up where I have to go back to Shelton and ask them, can we extend further? The only comment I can make on the audit is that there were very limited personnel records. So at that point in time, there is nothing, and even myself as an HR professional, I'm not going to go and open a can of worms. This is something that was before me because one, I don't want my name to be still on an audit showing that I went back to sufficient look for information that was not there. So unfortunately, it was not something that I could provide to the auditors at the time whenever they came asking questions about it because I'm looking at a personnel file that basically doesn't exist. And it wasn't just for this particular employee. This was across the board for personnel in general. So unfortunately, I get what happened, but there wasn't any additional things that we could offer to the auditor at that time.
Good. So let me ask this. You said there are very limited records. There's no computer record or anything like that. So let's say, he had 56 years of service. How far could we go back and look and see, did somebody on the board approve an extra day of vacation or something like that? How far can we go back and find? Can't find
Can
it.
we prove?
It's not there.
Vacation days or, did he ever?
And there were some book records that were left that we were able to go back and retain records to appropriately disperse that time that the employees had available. But unfortunately, in any case for administrators, that record was not there. He reported directly to the board, and in most circumstances, that CEO's record is not made available to the HR department. So basically, that is an agreement between him and the current board.
So he just gone to the board at some time during his 56 years and they told him, said, because you don't take any vacation or whatever it is, then we're going to include that in your pay.
Absolutely. And we don't know where the initiative came in. Unfortunately, everyone that was here during the time is no longer here. So, and of course, at that point in time, the system that they used was also the payroll person was not him. So we don't know what happened in that transactional exchange between the payroll personnel at that time, the CEO, in addition to the board. So that's why the recommendation from the audit was not to say to take that any steps further because we cannot justify that. There's not substantial evidence to make any acquisitions further.
And I'm assuming that the board would have had to have approved the financial report with that on there.
Absolutely, yes.
Any other questions on that part? Okay. We have, so item number 6, there is no action called for here, that I understand. I have one other, if I wanted to, Kenneth, do you mind weighing in on this? I just woke you up, but you. You know, I'd like to know, how you think that the company or the board, if we tried to call back this $80,000, what kind of chance would we have? Is that something that you would recommend that we pursue in spite of the fact that it doesn't say that the audit, recommends that?
No, because we can't determine whether or not he was owed that time or not. There's not enough records to determine what he did was right or wrong. It's an audit finding, and the audit's going to rely on what they found here. But we don't know what was, I think we can all attest to there were things done that there's no record of, but we know happened. And I think that's another one of these things. Plus, the optics of it as well with the litigation that we just resolved would have, I think it would have looked bad had we tried to call that money back. And I just think it would not have been a good idea.
It wouldn't have been something you would have recommended. I don't put words in.
No, that's correct.
Board has it? Yeah. No. All right, so let's go back to the report. Request for qualification on architectural and engineering services, and we also have this one for Brian signed up on.
Yes, sir.
Okay, another 3 minutes.
All right. Oh, out there. Had a hard time keeping my composure, but I will. All right, let me continue. On this particular agenda item, this is dealing with the board hiring the architects or engineers, do the planning, and be a project manager for the new hospital facility. I was on the board. We took over the hospital in November of 2023. And the whole fight was about that we was going to build a new hospital. We went through a lot of hard work with that, but we won the fight. And after that happened, the previous board was dismissed. Not just dismissed because they wanted to waste the money on the renovation, but it was dismissed because there were many violations here by that board and also by the former CEO, Mr. Vince Catara, just like the incident I just brought up. So we're here today because the Sunrise Community Group fought hard to get rid of the corruption we had here and bring in a new management so that we can provide quality health care for our residents here in West Ascension, Donaldsonville, Louisiana. That's why we're here today. If that old guard had stayed here, this building would still be empty. Nevertheless, being that we're close to now hiring the architects and engineers, the project manager for the new hospital facility, we need the board to move forward with a sense of diligence to get this done. November of this year will be 3 years. Now your RFQ for this, to obtain this project manager, the ends on the 4th of next month. So we're looking at sometime early next month. Let's hire who we're gonna hire, and then let's go forward. Man, let me tell y'all something. My good friend, my best friend, powerful man, powerful father, powerful husband, the late Kirk Mitchell. His last statement to me before he left here was, Glenn, make sure we build that new hospital. Well, it'll be 3 years this November, and we haven't even broke ground yet. River Parish Community College just had a groundbreaking, and they just announced their project a year ago. So, as far as we're concerned, we're dragging our feet on this. We need to get this done. We need to move forward diligently to build our new hospital. So when we get this project manager, the architects and engineers, let's go forward. We expect this from the board. We do not want no more delays. We want this done.
20 seconds.
I'm done on that one.
You done on that? Okay. All right, so we have, I asked Mr. Tucci to come and give us a report on this request for qualification.
Yeah, as Mr. Price, as Mr. Price stated, SOQs, the statements of qualifications are due on March 4th. We've got quite a lot of interest. We had questions referring questions from the potential submitters on the RFQ, but none were substantive enough to require an addendum to the RFQ. They were just minor clarifications. In fact, I answered one tonight. What I answered tonight just by email was, were there any questions? You know, and I said, yeah, there were, but none required any further clarifications or addenda to the RFQ. What happens now is, and I sent this to Shelton, I prepared a sort of a primer for the board, who's going to be the selection committee, to help lead you through, guide you through how to go about analyzing these statements of qualifications in the most efficient way you can, how to compare them to each other, and how to select the most. We know we're going to get, I talked to at least 3 contractors who I know are going to submit. There may be as many as 10. If there are that many SOQs to go through, you really hope there aren't, because it's quite a chore to go through. But I'm going to try to simplify the process for you as much as possible. Shelton is going to arrange for me to meet with 1 or 2 of you at a time to go through this PowerPoint presentation, this explanation of how I recommend you go through the SOQs, comparing to each other. Your goal is to shortlist 2 or 3 of these for oral presentations. That's what I recommend. Now, if one is just so outstanding in qualifications that you believe that they're so outstanding, you may elect just to, and if you're all in accord, I mean, if you're all in agreement, or if the consensus of the board is that this one is just more outstanding, you may elect not to go through the oral interview process and just select them. Then once an architect is selected, we're going to decide at some point what the delivery method is going to be. I recommended construction manager at risk, which is how we did the courthouse. Well, most hospitals, frankly, are being done now. There are quite good advantages for that sort of facility to be done by that delivery method. And I explained that method prior. If that is the case, you're going to have your architect, you're going to bounce things off back and forth between the board and the architect, and Shelton, and anybody else involved, to determine what you can do, how you're going to fund it, how much of a hospital you can do, do you have to stage the hospital, a lot of different things to discuss with that architect. And he's going to go through the 30% design stage. In accordance with state law, to use the CMAR process, you at 30%, you select a contractor. And you go through that process of selecting a contractor in a similar way. You put an RFQ out for contractors this time. Instead of a low bid process, you select a contractor based upon qualifications. And the architect will help do that. You select a contractor. The contractor and the architect will work together until the plan is not between 90 and 100% completed. They'll work together on those plans. At that point, the contractor would submit a guaranteed maximum price, which means here's what I'm going to build your hospital for, no more. And you decide if you can afford to do that at that point, and if you can, you'll contract with that contract. Anything ready? So the next step is we go through this training on how to review the SOQs.
Any other questions?
All I can tell you, I found somebody that's up at night. I found somebody. That's great. Oh, it's all different times. But now look, funny story. Not like you go.
I was looking for somebody else to talk to.
That's right. That's right.
Probably call me.
Yeah.
soon will the training be?
Next week, I'm gonna be working with each and every one of y'all on your timing, and we're gonna.
If we did it as a board, and you can't elect to do that, do this training, it's not any big secret, but it would be a public meeting. We'd have to announce it. But the training, I don't have a problem with doing the training at a public meeting. Absolutely. There you go. I mean, easier for me to do it one time.
Yeah.
Want to call a special meeting?
Yeah.
Special, okay, I'll work with you.
Y'all can agree upon a time and a date. As long as I'm not on a cruise, I'm not on my wife's birthday. Which is in April, shouldn't be. All right, thank you. Okay, item number 7, environmental care annual policy review and approval.
Yes. So, Mr. Dawson, I stand for you. I have Mr. Wayne Hoop, our environmental care director here. We have reviewed our policies 1 through 40, and they are up for annual review. So all I need a motion to approve the annual policies for this year.
Motion to approve the policies.
And a motion and a second. Any discussion? Any opposition? Hearing none, motion passes.
Next is our infection control, quality, and performance improvement. And Ms. Anastasia got those together for me. Ms. Crystal worked with her, and I'll stand before you to bring them before the board for our annual review of policies 1 through 42. So I would need a motion for this year.
So moved. Motion. Second. Any discussion? Any opposition? Hearing none, that motion is on.
Thank you, sir. And the next one is your cybersecurity and compliance program. We do have Ms. LaWanda here. So we have policies 1 through 12. So I stand before you to state if you can approve our cybersecurity and compliance program for our annual policy review.
So moved.
Got a motion?
Second.
Got a second. Any discussion? Any opposition? Hearing none, that motion passes.
Sir.
Okay, so,
One moment, Mr. President.
Yeah.
You're welcome.
So we have executive session, and you asked to speak on that. Yeah, 3 minutes.
Probably won't take but 2 minutes on this, Bill.
Hotel change, not. Just kidding.
You all about to go into executive session. It seemed like you're going in to talk about what you call strategic planning. It seemed like you're trying to keep your planning for the new hospital behind closed doors. In other words, meetings behind closed doors. The board is going to meet with maybe with the some of the administration and talk about how we're going to develop this new hospital. I think that you need to set up a community committee. I think you need to engage the community in this. I think our community needs assessment is what you need to really know. So if we're going to build a new hospital, we need to see what our community needs in that new hospital. One thing we do know the hospital is going to need is cardio medical services, because issues of heart attacks and strokes is a big issue in our community. We also know that we're going to need diabetes services in the new hospital facility, because diabetes is a big problem. A lot of our residents are diabetic. Again, I don't think you should have these almost like secret meetings using statute Title 46-1073 to do this, but I think you're making a mistake. Executive session should only be used for litigations, lawsuits, those type of matters. But when you're talking about building a new hospital, you need to open it up to the entire community. And the community engagement needs to be a part of this. So I advise you not to go in there and come back and approve that you are going to have these secret meetings concerning the building of this new hospital. Our last comment, as a whole today, I pray that this board will do the right thing, and then therefore we won't have any problems. If not, we will.
Mr. Price, I'm glad you mentioned community needs assessment. So we are working with Rudy, your buddy. So he's working on our community needs assessment, because you remember the last time that we did our community needs assessment was in 2019. So now we're making sure that we're working on it.
Yes, sir.
Okay, so we're ready to move into executive
Yes, sir.
session.
I made that motion.
Got a motion, to move into executive session, got a second. We're gonna need to do a roll call thing.
Dawson,
Yeah.
Lee,
Yes.
Ms. Williams,
Yes.
Ms. Mitchell,
Yes.
Mr. Mayor.
Yes.